Welcome everyone to this webinar for World Cancer Day 2024. We're delighted to have so many people joining us for this session. My name is Hayley Jones and I'm the Director of the McCabe Centre for Law and Cancer, which is based in Melbourne, Australia, and we're a joint initiative of Cancer Council Victoria, the Union for International Cancer Control and Cancer Council Australia, and we're thrilled to be hosting this webinar today. So today we're going to be discussing the topic of closing the care gap in the Asia Pacific region. And we're really thrilled to be joined by a fantastic panel of speakers with diverse experience to share their insights on the cancer equity gap in their own countries. Please note that today's webinar session is being recorded and will be made available on the McCabe Centre's website after the event. If you don't wish to be recorded, please make sure to turn off your camera. So it's the third year which World Cancer Day has focused on closing the care gap, which is a really fitting topic given the inequities which persist in cancer. While we live in a time of amazing advancements in cancer prevention, diagnosis and treatment, many of us who seek cancer care hit barriers. Income, education, geographical location and discrimination based on ethnicity, gender, sexual orientation, age, disability and lifestyle are just a few of the factors that will influence cancer care. And globally, we know that as of 2021, at least 4.5 billion people, or more than half of the world's population, were not covered by essential health services. 2 billion people experience financial hardship due to healthcare costs, and more than 1.3 billion people were pushed or further pushed into poverty when trying to access basic healthcare. In the Asia Pacific region, we have one of the most diverse regions on Earth, with countries with huge populations of more than 1 billion people and much smaller countries with populations of just a few thousand. We have rich and poor, and we have some countries with exploding populations and others that are rapidly aging. We have really varied geography and culture with island nations, countries stretching across vast mountains and plains, huge urban centres and isolated villages. And all of this variation means that we have really different experiences of cancer prevention and care. Reports presented recently at the WHO Executive Board meeting just last week give more context to the growing burden of cancer and some of the opportunities that are yet to be taken up to reduce cancer risk factors. And these reports show that cancer is responsible for 1 in 6 deaths globally, and this figure is unfortunately expected to nearly double by 2040, especially in least developed countries. Tobacco use is declining globally, but is not declining fast enough to meet the 2025 target. Alcohol consumption per person has declined since 2015 worldwide, but this decline is uneven across regions, and increases in Southeast Asia and the Western Pacific region have been seen. And overweight and obesity are projected to cost US $3 trillion per year by 2030 and over 18 trillion by 2060 if no action is taken. The In Progress report presented to the WHO Executive Board on social determinants of health show that while progress has been made in meeting targets aimed at reducing gaps in life expectancy, mortality rates, and maternal and child mortality, significant inequalities remain, and disadvantaged groups still experience noticeably shorter and less healthy lives. Recommendations in that report include addressing economic inequality and investing in universal public services for health equity and well-being, promoting inclusive governance for people-centred services, taking collective action to address health equity amidst climate change and societal transitions, and establishing a healthcare sector that ensures equitable access and genuine participation. So while significant strides have been made in cancer care and in strengthening health systems, there is still a long way to go. Beyond merely identifying gaps in access, today we hope to spotlight and learn from some of the best practices amongst Asian Pacific nations on closing the cancer care gap and encourage regional collaboration and exchange. These insights not only have the potential to advance cancer care, but also to contribute to health equity in the region and on a global scale. So before we turn to our speakers, I'd like to outline the format of today's session. So we'll be hearing from each of our speakers in turn about a key issue of inequity in cancer, which their organisation has been seeking to address in their country. We'll then have some more general discussion, and the opportunity for questions from the audience will be possible at any time. please feel free to type your questions into the chat, and we'll have a good length of time at the end of the session to go through those, and we do encourage that interactivity. So now to introduce the first of our fantastic speakers. So our first speaker today will be Dr. Melissa Lim Suohan, who's a lecturer at the University Malaysia Sarawak. She has 13 years of experience as a clinical pharmacist under the Ministry of Health in Malaysia, and obtained her PhD in medical sciences at Okayama University in Japan. Melissa's professional interests include cancer therapeutics, theranostics, pharmacogenetics, access to cancer diagnosis and therapeutics, and women's cancers. She is a Young Leaders alumni of the Union for International Cancer Control and a caregiver and patient advocate. And Melissa also co-founded the Society for Cancer Advocacy and Awareness Kuching, or SCAN, amongst her many, many other achievements. Welcome, Melissa. And I'm really interested to hear the country context for you from Malaysia about the cancer care gap.
Thank you, Haley, for the very good introduction. I'm very happy to be here today. Nice to meet everyone. Firstly, I would like to talk more about where I'm from. I'm from Sarawak, the largest state in Malaysia, which is located in the island of Borneo. So the state of Sarawak itself is as huge as the whole of Peninsular Malaysia. This is just to give you a live view of what it's like in Sarawak. So in Sarawak, we have about 3 million population. 1.5 million of them are women. Okay, over 150,000, over 125,000 kilometers square areas. We only have one tertiary cancer center, fully equipped with radiotherapy and chemotherapy. So there's a lot of logistic issues going on around here. About 45% of the population actually live in rural regions of Sarawak, and 70% of the local people actually depends on the public healthcare system. So meaning to say that there's a lot of shortages in manpower, patient overload, especially those located in the urban settings. So this actually caused a lot of disparities, especially on the more rural areas besides the urban areas. So there's been a lot of serious delays in call and recall of cancer screening. And one study has even reported that almost 50% of breast cancer patients, which is the highest rate of breast cancer, most common breast cancer in the whole of Malaysia and also Sarawak, were notified more than 6 months after consultation. Thirdly, another barrier that we have is the cultural and language barriers, whereby due to the lack of awareness in early signs of breast cancer and other cancers, they ended up depending and believing in traditional medicines when they get sick. We have over 30 ethnic groups in Sarawak itself, each having their own language, each having their native languages. So it is also another barrier for us to educate them about cancer in their native languages. So what we did in collaboration with the Society for Cancer Advocacy and Awareness Kuching, which is SCAN in short, and also the South Breast Cancer Support Group, is that we have been trying to work on closing the care gap to breast cancer screening and access to treatment. As we know that this is the highest rate of cancer in the whole of Malaysia and also Sarawak. So we are trying to, what we did was that we go into the rural areas of Sarawak. So we provide them with breast CV, clinical breast examination screening, and we try to navigate this woman out to the nearest clinic and also to the tertiary hospital to get treatments along the way. So this is just to give a brief insight about what we've been doing in our area. Back to you, Haley.
Thanks so much, Melissa. Yeah, there's definitely some big challenges there, but certainly some challenges that are also faced in other countries in similar ways. Okay, I might turn to Amanda Piper, our next speaker, who's the head of cancer strategy at Cancer Council Victoria, where she leads the team to investigate system-level issues through engagement in order to improve cancer experiences through advocacy and education. Amanda's focus is to drive reforms that improve health equity. Amanda also supports multidisciplinary collaborations that involve clinicians, researchers, policymakers, and individuals impacted by cancer. Amanda, could you tell us a little bit more about your work and the context of the care gap that you're dealing with?
Thanks, Hayley, and I'm also delighted to be joining you in this webinar, and thanks everyone for dialing in. I'd like to acknowledge that I'm dialing in from the lands of the Wurundjeri Woiwurrung people of the Kulin Nation and pay my respects to elders past, present and future, and any Aboriginal people who may be joining us today. I'm joining you from the state of Victoria, and like Melissa, I'd like to just put that into a bit of context. Victoria is physically the second smallest state in Australia. And having said that, it's about the size of the United Kingdom. So it's still quite a large space. And then we've also got the second largest population of Australia. So we've got about 6.5 million people who live in Victoria. About a third of those people will live in what we would call a rural or regional area outside of the kind of metropolitan centres. And then we've also got about a third of the population who were born overseas. There's other elements of diversity in the Victorian state. And one of the areas of focus for my team and the organisation within which I'm working at Cancer Council Victoria is on improving people's experiences of cancer. I've got a particular focus on once people have been diagnosed with cancer. And we know that there are discrepancies in the experiences that people have in the Victorian state. One of the particular areas of focus for us is around the experiences of people who live in regional Victoria. And we know that, unfortunately, regional Victorians are 10% more likely to be diagnosed with cancer and that they're 16% more likely to die of cancer. So for us and the work that we do, we're particularly interested in how can we improve people's experiences once they're diagnosed, what are the supports that people can be offered, and we've got a number of programs that we've been able to deliver to try and better understand why there are barriers and gaps, collaborate with health professionals and health services in regional areas, and extend the support that we're able to offer, as well as the connections that our teams can make to other services so that people have better access to supportive care. I think I'll stop there, Hayley, and happy to continue afterwards.
Great, thanks, Amanda. That's a great overview. Next, I'd like to turn to Belinda, who's joining us from Fiji. Belinda Chan is the CEO of Fiji Cancer Society, and she's held this position since 2017. She holds a Bachelor of Arts in Applied Psychology and Management and a postgraduate diploma in psychology from the University of the South Pacific. And the Fiji Cancer Society was founded back in 1993 and is the national cancer society in Fiji. Belinda, could you explain a bit more about the context of cancer in Fiji and perhaps some more around the cancer care gap that you've been focusing on, understand particularly relating to palliative care?
Thank you, Hayley. Good afternoon, everyone, and thank you for tuning in. Where do I start? So I'll just start with our little island population. We're about 929,000, multiracial. In terms of our health infrastructure, we have the three main hospitals in the Central Division in Suva, and then in the north in Lambasa, and then there's one in Lautoka, which is a private-public partnership. All these three hospitals offer some kind of cancer treatment, which is basically surgery, chemotherapy. With regards to radiation, patients are then recommended to travel overseas for that. And most times it's also through insurance. There is a allocation through the annual government budget for overseas treatment. So that's what the patients who are unable to afford are able to access. In Fiji, with regards, there's a lot of cancer, there's a lot of gaps in the cancer continuum here in Fiji. You know, starting from awareness right through to palliative care. And over the years, we've noticed, you know, so many gaps and tried to figure out how we were going to address it. In 2021, we discussed about the possibility of conducting a palliative program, which we introduced in 2022. And that was through donor funding that enabled us to roll out this program. And it's something that I'm going to talk a bit later about. So like Amanda, I'm going to end it here, Hayley, and then talk more about the program later on. Thank you.
Fantastic. Thank you, Belinda. And our final speaker, welcome to the panel, is Associate Professor Jason Gurney, a cancer epidemiologist within Te Aho Te Kahu, the Cancer Control Agency, and also a director of the Cancer and Chronic Conditions, or C3, research group at the University of Otago, Wellington in New Zealand. And Jason's research focuses on describing and understanding inequities in cancer outcomes, including treatment access between Indigenous Maori and non-Indigenous peoples in Aotearoa, New Zealand. Jason, would be really interested to hear your perspective on the care gaps that you've been looking at.
Well, kia ora, Hayley, and thank you everyone for joining. It's really nice to be here. I just want to acknowledge that I've been asked to speak for 5 minutes, which would be a world record for me because I'm used to speaking for much longer than that. So good luck to me in advance. No, it's really nice to be here. Thank you very much. And it's a great thing to be talking about on World Cancer Day, the issue of inequity. Just to pick up on something that Belinda just said, she said, "Where do I start?" And I think that's my favorite quote so far. Where do I start? So the thing I'm going to talk about today is the in a broad sense is the survival gap between our Indigenous Māori population and the non-Indigenous population, more specifically our Pākehā or European population, which is the majority population in Aotearoa, New Zealand. So for around 23 of the 24 most common cancers diagnosed in New Zealand, Māori are more likely to die of that cancer relative to the non-Māori population. So it's a big problem. It's kind of seen across the spectrum. There's nowhere really to hide, but the reasons for that survival disparity is many and varied. And actually, when you drill down on certain cancers, it's because, you know, early diagnosis was missed more consistently for this cancer over here, but actually it's not a problem for this cancer over here. So it's kind of a multiple and varied problem. What we've been doing recently, the thing I'm going to talk about today, and it's a consistent theme that has come through several of the speakers so far, has been this problem of geographic barriers to accessing care. So one of the pathways by which Māori have poor survival is through poor access to care, including surgery, radiation therapy, and chemotherapy. So the best practice type care for their cancer end stage. And our research, so I have that 2 hats that you mentioned, Hayley. So I have one hat where I sit as the epidemiologist for Te Aho Te Kahu, our cancer control agency. So that's the government. And the other hat is our research group. So within our research group, we've been doing some work looking at disparities and how far Māori have to travel to access care relative to Europeans. And what we found is some really consistent themes around cancers that require centralisation of care, because Māori are more likely to live rurally. Most Māori do live in urban environments, but Māori are more likely to live rurally. And so what we've found, particularly in the context, say, for example, of liver cancer, is that Māori are having to travel twice as far for twice as long to access liver cancer surgery compared to the same European patient. That's confounded or compounded by the fact that Māori also are substantially more likely to be deprived and live in deprived areas and have less resources to access that care, to be able to travel to that care. And so it's kind of a nested problem. There's a series of problems that we're dealing with in New Zealand to address this. Within the Cancer Control Agency, one of the ways that the levers that the government has to try to address this problem is through something called the National Travel Assistance Program. And that's essentially a program that funds people to access their care. So it gives people money so they can travel to access care. What I just said there is an extreme oversimplification of what it does, and which is part of the problem. So we haven't had a system that's really been fit for purpose for quite some time. For example, for a long time, and I'm pretty sure it's still the case, it worked on a reimbursement only scheme. So you still had to pay and then get reimbursed. But if people don't have money in the first place, well, I mean, you can imagine. So the National Travel Assistance Scheme is something that Te Aho Te Kahu is really well placed to provide advice and analysis to government regarding what we should be doing with the scheme. So it's currently under reform. Te Aho Te Kahu doesn't control the National Travel Assistance Scheme. It's controlled by Health New Zealand, which is kind of the commissioning agency for the government. But what we have is the ability to influence. So we like to provide evidence and supply the best evidence to make sure that our cancer patients are getting exactly what they need. We're fairly sure Māori aren't getting enough assistance. So at the moment, we're doing a project to look at what assistance is being provided right now. How is that patterned by things like ethnicity, cancer type, all those sorts of things, because even that basic analysis just hasn't been done yet. So it's something that is a very active piece of work that the agency is working on at the moment. So I'll leave it there like everyone else. So again, it's a very nested problem that sits within a bunch of other problems, just I think like the other speakers have already spoken about. So kia ora, thank you.
Thank you, Jason. And where do we start? I think we've made a really good start. So thank you to all the panelists for your initial thoughts on this topic. And I'd like to come back to you all to think about how has law and policy played a role in addressing or reducing these inequities? And if you'd like to expand on the topic that you've already discussed, we'd be happy to hear some further thoughts. So might go back to Melissa, first of all, to see your further thoughts on this point.
Well, I was pretty intrigued by what Jason mentioned earlier about how the National Travel Assistance Program can actually provide people money for people to give access, so that they can get to the place where they're supposed to get treatment for. In Malaysia, we don't have this system. So we are now working on a patient navigation system, but it's still very preliminary. We are working on the data, getting data. So it was from, I think, Cancer Research Malaysia doing like sporadic researches and getting, in setting up the system, proper system for patient navigation. So we are still building this in hope that one day we can get the Ministry of Health or Ministry of, what do you call it, social support or something, so they can actually put this in action, that we could get this up, and then the government could actually provide an act of sort to provide access for the inequities in cancer care for these patients or for the populations of the whole of Malaysia, not only Sarawak. There's also indigenous population in Peninsular Malaysia as well, who have problems in getting access to not only cancer care, but in general, any kind of care. So the other thing that I think that law and policy can actually play a role is that they can also help to mandate educational programs in schools. For example, for breast cancer, we've been doing like very opportunistic screening. We've been going to places and we just sit there and wait for the villagers to come to us. I mean, we did a preliminary meetings with the head of villages and stuff like that, but we are just sitting there and waiting for them to come to us instead of doing a systematic screening system. So if we can actually, we were thinking about this, if we can actually implement this in schools, like in elementary schools, in secondary schools in Malaysia, so that the teenage children can actually get a glimpse of what breast cancer symptoms, sign and symptom is like. Then this can actually be something that laws can do for our region. Back to you, Hetty.
Thanks, Melissa. And Amanda, I know that for some time the issue of travel subsidies has been one that Cancer Council has worked on, both at the state level and at the federal level. Is there anything you'd like to share on that topic, and also respond more broadly on how law and policy can play a role in addressing these inequities?
I was very interested in hearing how New Zealand has been approaching the travel issues, and we've got a very similar scheme in place in Australia. Each state has its own iteration of a travel scheme, and the complex factor in Australia is we've got a federated model. So we've got our Commonwealth approach, which is that there is some federal direction from the Department of Health to I suppose, provide the framework to encourage having a travel scheme, but it's up to each state then with their own governance and government frameworks to decide on the parameters of that scheme and then to implement it. And so we have absolutely had a scheme in place to support Victorian patients who need to travel, whether it be for cancer or other kind of illnesses. And we've identified that there are gaps in inequities, that particularly when someone has to travel really frequently for cancer, we still have a circumstance where people have to pay up front and then get reimbursed. So Jason, hearing that you've been able to overcome that already is something that's quite, we'll take that offline. That's something that we want to work on. The environment that we sit in is that we can influence and provide feedback and input into the Victorian Department of Health But it is ultimately up to the Department of Health and the Victorian government to look at the budget, look at the other expenses that that they're facing, and then make decisions on where best to allocate funds. And so that's a challenge for us because we would like to have a more active role in supporting people with lived experience to share their perspective on the inequities in that system. But it's not always possible for those types of interactions and conversations to be brokered in a Department of Health setting. So I think considering the travel side, that's an absolute challenge for people in Victoria, and it is absolutely one of the reasons why we see that there are differences in people's life expectancy when they've been diagnosed with cancer and the types of treatments that they might ultimately choose to access. That, a bit like Jason was referring to, sits within this kind of complex nested system. So what I would say is a positive in Victoria is that we've got something called a Victorian Cancer Plan, and that is supported by an act of law. So it's under the legislation in Victoria called the Improving Cancer Outcomes Act. That's really beneficial to us and all of the people in the cancer control sector, because what it means is that by having it legislated, by having the legislation require a plan every 4 years, no matter what's going on in a kind of political landscape or competing priorities, it kind of gives this cadence and this responsibility and a structure to say, how are we improving our outcomes? What outcomes are we looking at? And then what are the priorities that the Department of Health will invest in every 4 years? It's not perfect, and we are fortunate to have an environment which encourages submissions from the cancer sector to inform each version of the cancer plan. So there is a lot of opportunity for collaboration. And I know that's something that we want to talk about a little bit later. So I think there's some positives and there's absolutely some opportunities for us to learn from some of the other countries in this region.
Thanks, Amanda. And Belinda, I'll come back to you. Are there any points that you'd like to make in response to the discussion so far, and particularly whether law and policy has played a role in Fiji in addressing inequities?
Thanks, Hayley. Right now, there's really no law or policy in place per se. I'm like Melissa and Amanda, I'm going to refer to Jason's National Travel Assistance. So as an NGO, we have that bit of flexibility where we're able to provide these services to patients. And so we do provide transport in the form of, it's car, bus, boat transfer, including ambulance for our patients. And that's not only in the Central Division, but it's also in the West and in the Northern Division. It chews up quite a bit of our operating expenses. But the only reason why we keep doing it is that we have seen an increase of patients returning to complete and to complete their treatment, and so that for us is something that we want to pursue. Just last year in October, the government has committed some form of budget support to allow us to do what we do. Like I said, it's not only. We have a lot of issues. So, from medicine, chemo drugs procurement, and then, we want to make sure that our patients are able to access all this. So a lot of gaps. It's hard to prioritize because everything is important. We just got to pick something that we feel that would be beneficial and help ease the burden at the hospital. So, the transportation assistance is what has helped considerably. And but definitely we do need some law and policies in place. We have various NGOs doing some form of cancer screening in the cancer space, but it's all been done in silos. So it's a matter of bringing everyone together. But then the question we ask is, whose role is it? Is it us as the leading cancer organization here in Fiji, or is it the role of the ministry? If we do it, do we get the support of the ministry? So just things like that we need to consider. And hopefully that, you know, over the next couple of years, we're able to just narrow that gap a little bit better. Thank you.
Thanks, Belinda. And Jason, I'll come back to you. And I know you've got a lot to say, and we're all very interested to hear more of your thoughts. So I'd be interested to know if you've got further comments that you'd like to make on that topic, or more broadly on how law and policy can play a role in reducing inequities.
It's never a good idea to let me say more, Hayley. But no, thank you. So just to clarify about, because we've talked about the travel assistance, which is great. I'm very pleased that we're talking about that, and understanding that it's kind of a problem for everyone is good to hear. You know, friends in misery. So I think important to say that not everyone with cancer gets the NTA. So there's an eligibility criteria that you have to fit, and it has to do with how far you have to travel, how many times you're traveling. Part of it, I think, is partially means tested in that if you have a community services card, which has to do with income, you can also qualify. So it's not as straightforward as I'm going to get cancer treatment, give me money. That's not how it works at all. And we don't know if the system's working at all for cancer patients. That's the problem. So that's why we're doing at Te Aho, that's why we want to do some of this analysis, because it just hasn't been looked at. So that's just that, finishing off that first point. With respect to law and policy, those things are, I think it's a great question, because they're absolutely fundamental to cancer control within any of our countries, and in particular the cancer services. If you don't have the legislative requirement, if the government doesn't have a legislative requirement to deliver on X, Y, Z, it won't. It's absolutely essential. So we're very fortunate in that we also have a cancer action plan, which happened about 4 years ago. We had a series of events happened under the then government, where we had a cancer plan happen through a very strategic means driven by the sector, essentially. We had a cancer action plan which led to the development of Te Aho Te Kahu Cancer Control Agency. So the agency itself is only about 3 or 4 years old. That came out of putting pressure on central government to make that happen. We also have something called the Pai Order Act, which is kind of a Health in All Policies Act. So that's a piece of legislation that the last government passed, which gives kind of a lot of room to bring health into all things that we do. So there's lots of stuff that's come through as a result of that, including one of the other things that's happened is the health reforms, which have led to kind of a change in the way our health system is organized, and that's all come from legislative change. So yeah, policy and politics are completely essential to getting forward momentum in the area of cancer control and improvement in cancer services.
Thanks, Jason. That's really interesting to hear that the agency is relatively recent. And I'm just picking up on one of the questions that's come through on the chat. So perhaps I'll just come back to you briefly. There's a question in the chat regarding the new New Zealand government and how that might influence the treatment gap for Maori people. And I'm just wondering, I guess, more broadly, with some of the structures that you've just mentioned that have been put in place, is that giving some longevity in terms of the cancer programs and initiatives that are being set up that may make them less liable to the changing political winds over time?
I think so. I think that the second part is essential to answering the first one, really. So having a plan and having an agency are prophylactic, if you know what I mean, because you create these, they can very easily be quashed, but the idea is within Te Aho Te Kahu, we want to exist until we're not needed anymore, which is probably going to be never. So we have to maneuver with whatever is in front of us, play the ball that's getting bowled to us, if I can use a bowling analogy, rather than worrying too much about the other things. So with respect to the current government, there's definitely been a very recent change in government. So it remains to be seen what this government's going to do in terms of closing service gaps. Depending on who you are talking to, it could be a bad thing or it could be a good thing. It's definitely a bit more challenging in terms of equity. So in terms of focusing explicitly on solving problems for Māori, that's going to be more tricky to get across the line with the current government, because that is not one of their priorities, if I can stay reasonably neutral. But as far as we're concerned, the job stays the same. And if we have to use different words and get things done more strategically, then that's what we do. We just have to, again, be strategic and think things through when we're asking for things. Maybe be careful about how we frame them and make sure that have an eye on the prize rather than trying to get caught up in philosophical differences, because ultimately those philosophical differences can drive things to a halt. So our goal is just to keep moving and using whatever language we have to use.
Great. Focusing on getting things done. Fantastic. Thanks, Jason. I just wanted to pick up on a comment that Belinda made a little bit earlier around collaboration to address some of these issues. And I'd be interested if our panelists could sort of expand on how you've collaborated with other organisations, or if you've got active collaborations to try and address some of the inequities that you've seen. And I'll come back to Melissa first of all.
Yeah, thank you, Hayley. We have collaborated with a few NGOs, like for example, SCAN has collaborated with the South Breast Cancer Support Group, which is another NGO. So South Breast Cancer Support Group actually have a huge disciplinary of nurses that can do breast self-examination and also clinical breast examination. So this is why we need to incorporate both groups in order to have a more efficient system in terms of outreach programs. So SCAN is the voice for everyone's advocacy group, and while South Breast Cancer actually is the muscle group. So we provide we provide services and stuff like that. So the other collaboration that we have is with the Ministry of Health, definitely. So we have to connect with the smaller clinics which are in the rural areas of this is talking about our outreach programs context. So we have to collaborate with Ministry of Health and also the Ministry of Women, Early Childhood and Community Wellbeing Development. So it's a whole nested system, like everyone has mentioned before. It's a complex system, so we need help from every single ministry, if possible. So there's what we did over in Sarawak. And but I do resonate with what Belinda has said previously about we've been doing a lot, we've been doing a lot of advocacy, we've been doing a lot of outreach programs, but do we get support from the ministry? That is the bigger question. Like, how much do we have to fight? How much do we have to nag them in order for them to, hear us and bring this up as a bill? And a bill is a bill, and most bills goes unnoticed by, member of parliaments and all that. So how much do we have to do to get supported by the government and the ministries? Yeah, over to you, Hayley.
Yeah, very good questions, Melissa. And Amanda, I might come to you next, just for your thoughts on collaboration. I know that Cancer Council has some strong collaborations over time, both with government and with other agencies. Could you expand on some of that work that you've done?
Yeah, for sure. And I think there's absolutely some parallels with what Melissa was just referring to in terms of we are an organisation that undertakes advocacy, and we're also an organisation that provides services. And so in the last couple of years, particularly what we found as perhaps a silver lining in a time of adversity was that COVID caused a lot of change in Victoria, as it did in every country. But what we were seeing is that there were some really drastic changes in people's participation in screening, in the capacity of health services to support people with cancer whilst also dealing with a pandemic. And so the silver lining in that is that we were able to, luckily, step in and play a slightly larger role in offering our services and support. We've got a telephone-based service, so from an access perspective, it was really quick and easy for us to shift our nurses to work from home and still maintain service delivery. And it was quite a safe setting for the nurses, because then it meant that they were still able to offer that function without being exposed to COVID, and people who were impacted by cancer could access it. And so we joined part of a kind of a network that was stood up really quickly by a whole range of different organisations, health services, the Department of Health and other not-for-profits, to come together regularly and talk about the inequity and challenges that people were experiencing, and what were the solutions and what could be done. And since COVID started to settle down a little bit, it allowed us the opportunity to say to the Department of Health, this is something that's been impactful. We see that it's taking a bit of pressure off the health sector, and we see that there's opportunity for us to do more to improve our role in offering supportive care to people impacted by cancer. And so we were able to get some funding as a result of that, as a bit of a pilot project to see what difference would that make. Is it going to both address people's needs as well as potentially releasing some of that pressure and kind of stress within the health workforce, particularly in the regional areas. And we've learnt a lot from that project. We've had some terrific collaborators who, in Victoria, we've got a number of different governance arrangements for cancer service delivery. And so we partner with one of, with several of those types of governance arrangements, one of which is called the Integrated Cancer Services, and they oversee and sort of provide quality support to different regions within the state. And through those partnerships and collaborations, we were able to turn around kind of education, provide better pathways and referral pathways for patients, and we've seen improved outcomes. And we're hoping that we'll be able to continue that work. But I think what it also has highlighted to us and others in the sector is trying to establish whose role is it, and how clear and easy is it for someone as a person impacted by cancer to navigate the system, and equally how hard might it be for a health professional to keep track of how that system might be changing. So it's a work in progress is how I would say, how I would end it.
Thanks, Amanda. And Belinda, I guess you sort of touched on this issue of collaboration and some of the challenges and the role that the Fiji Cancer Society should play. Do you have further thoughts on collaboration or other opportunities that you see in closing the care gap?
There are opportunities. I mean, for us here in Fiji, there are opportunities out there. And I guess because with NGOs, we're all after that same pot of gold. And because the Cancer Society is just focused only on cancer, specific to cancer, you've got other NGOs that are not only doing cervical screening or breast screening or PSA testing, they've also included other projects, so maternal child health, all of that down the line. And so that's where the competition is for us. But if we talk about collaboration with them, it comes back to who gets the data. So sharing of data is one thing that everyone becomes territorial and nobody wants to share their data. And if we share our data with the ministry, I mean, for us, we work very closely with the ministry, and we understand the need why we should collaborate with the ministry, because they're providing the clinical services. It's just, you know, getting the NGOs that are here, getting them to change their mindsets, that at the end of the day, it's more about the community. It's more about the individuals in the community that we should be focusing on, rather than putting our own agendas in the forefront. How do we work with that? You know, so like I said, it becomes very competitive for us. There are days where I feel that we haven't done enough. When I look at the number of patients come in and thank us, acknowledge us for our work, and acknowledge other people, the oncology team, I feel humbled because of that. But when it comes with working with other NGOs, you know, one is the data, the other one is results. You know, how do we get them to pass on their results onto us to allow us to have that pathway? There's no follow-up from their end. It's a bit difficult, because whenever they want something done from us, we always oblige. You know, it's the patient, it's the people that matters, and it's not about the organization. Some say I'm too soft, but I think at the end of the day, it's more about the individual that comes to us for help, and not about the organization. Well, as long as you're able to achieve the objectives and your strategic goals that you have set in place. But Yeah, NGOs seem to be a barrier for us with collaboration. We don't have anything formalized with the ministry. There's opportunities for us to work with other government departments. But again, we don't, it's the Ministry of Health is more or less our line government department. We can't be seeing, I don't think it's right for us to be signing MOUs with Ministry for Women when we have yet to sign an MOU with the Ministry of Health. So how do I get that turned around in our favor? And how do we get people to understand that cancer is not only our problem, but is the problem of everyone else here in Fiji? And how do we push and lobby with government to ensure that we have laws and legislations in place that will close that care gap, that will improve the services offered to patients who have a cancer diagnosis? So yeah, I'm going to stop now.
Yeah, thanks for sharing that, Melinda. It certainly is a complex area, and I can certainly understand the concerns with competing priorities and competing efforts over limited funding, which we know is an issue all over the world in terms of low amounts of development funding relating to non-communicable diseases and cancer in particular. Jason, I will come back to you, but just before I do, I would encourage if there are any other questions in the chat for people to please add your questions, and we'll come to those. We do have a question relating to prostate cancer treatment, which I'll just put on the table and see if anybody does have expertise in that area. But we might come back to that one because, Jason, I'm interested, given that you're on the cancer agency side and also have access to presumably lots and lots of data around cancer, do you have any sort of suggestions or advice for people who are perhaps more on the NGO or advocacy side on effective ways of working with government or cancer agencies for the most productive outcomes?
What a great question. Wasn't expecting that one. Nice. Well, I wear a couple of hats, obviously, with the university and also the Cancer Control Agency, but I was also on the board of one of our local divisions of the Cancer Society. So I've had a little bit of a, the New Zealand Cancer Society. So I've had a little bit of a look behind that door as well, which was really useful, and I enjoyed my time with that society. I think that, sorry, the volunteer firefighter sirens going off here, if anyone can hear sirens, so I apologize if you can. So I think it's quite tricky when you have a lot of voices trying to get the attention of one organization. So essentially the go-to place for cancer charities across New Zealand to attract attention is really Te Kahu Cancer Control Agency. That's kind of, wasn't that case 5 years ago, but now that's kind of their pathway through to policy. And so it's quite hard actually for the agency to navigate that and to manage those relationships. I would say one thing that I have a lot of time for is when those charities kind of combine together as one voice. And so I think there's an organization called CanGo, and I apologize that if I've got that wrong, but essentially it stands for Cancer NGOs, and it's called CanGo. I think it's abbreviated to that. And it's kind of most of the bigger charities, cancer charities in New Zealand. But I think there's dozens and dozens of cancer charities in New Zealand. So it's not straightforward. Cancer Society is the biggest. Breast Cancer Foundation, I think, is probably around the second or so in terms of size. So organizing NGOs together so that the NGOs are talking to each other first and then going together to whoever is in the position of power that you're trying to attract would be my one piece of advice, because that can be quite effective. Yeah, and there are things also, and seeing yourselves, offering yourselves as a means by which the government, or say an organization which is kind of arm's length from government in terms of making commissioning and those sorts of things, like the Cancer Control Agency, being the way that they can say things that they maybe actually can't say out loud, but they're thinking it, if that makes sense. So being prepared to get your hands dirty and be on board with what the people that are in those positions are actually wanting, but can't say them out loud because for political reasons or whatever. So understanding where you sit strategically and then playing that role in a collaborative way rather than an obstructive way, because I tell you the number one way to get people to stop listening to you at government is to just be obstructive and horrible all the time. They'll just stop talking to you. So you might have philosophical differences again with someone or the agency about something, but talk about the things that you agree on, not the ones that you don't, and you'll find that you'll build that relationship, and then all of a sudden the other things are on the table as well. That's my long-winded piece of advice.
Very helpful to get your thoughts on that, Jason. Thank you very much. So we've got some great questions coming through on the chat. So I might turn to some of those and I'll put forward a couple of them just so that we can get through them. So there is a question around prostate cancer screening and treatment in different countries and what is available. And we've also got a question around lung cancer screening in Australia recently. There's been a launch in 2025 relating to lung cancer screening, and I understand that there has been already a program in New Zealand around lung cancer screening. So I am unaware as to whether the panel has expertise in either lung or prostate cancer screening or treatment, but if anybody does, feel free to jump in here and answer these questions that have come through from our lovely audience.
All I can say from the New Zealand side is that yes, there's a lung cancer screening kind of pilot program happening at the moment. Prostate cancer screening is still not on the agenda, and I won't touch that one despite the invitation. Yeah, lung is on the agenda. It might be just like I was talking about before, in order to get that across the line, because it has a very strong equity ramification. Lung cancer is very important for Māori. Much more likely to get lung cancer and die from it. So we're going to have to be strategic with that one in terms of getting it across the line, but certainly a few years down the track in terms of pilot testing.
Great, thank you. Amanda.
I don't have a lot of expertise in both of those areas, but I can comment that one of the benefits we've got is that there are a lot of different organisations and experts who are coming together to inform some of these pieces of work. So I think in the chat I saw there was some mention of with prostate cancer, there's a review of guidelines, and there's been a fair bit of investment into the sector over time to better communicate and the approach to prostate cancer screening. And there's more work to be done in that space. There's absolutely no question. But I think that's one opportunity, is to have the clinical guidance and then to look at the best ways to communicate, disseminate and support access to screening. And similarly, when it comes to lung cancer screening, I know there's a number of different organisations who are starting to connect together to seek opportunities to support pilots in the Australian setting, and to take the learnings that have been gathered from other screening programs within Australia and see how they might translate into lung cancer screening. But it's very early days, so I think we'll be looking to other countries as well for what's been going on there.
Thank you. Another great question that's come through is around the role of community health workers and if they are being tapped to close the gap in Indigenous communities or in geographically isolated areas. And if they are, how are they being used and what benefits or incentives do they receive? So Melissa and Belinda, I'm not sure if you've got programs for community health workers in your countries, but if you'd like to comment on that, or Jason or Amanda as well, but perhaps we'll start with Melissa and Belinda. We'd be really interested to hear your comments.
Thank you for the question. We do have what we call the community champions that we actually hire for cervical cancer screenings in Sarawak and also in Peninsular Malaysia. So we have this initiative by Rose. It's I think, reduction to access to cervical screening program. So so they are hiring people from, actually we call them community champions, but most of them are actually retired nurses. So meaning to say that they do have a specific experience in healthcare, but at the same time they are retired, so they're basically free. So we actually just hire them for like a whole month or 2 or 3 months, depending on the project of our outreach. And then so these community champions will go into specific rural areas which they have basically have more voice to say, and then people trust them in that area, and then they will talk to the villages and get them to register for, like, for example, HPV DNA screening. And so that on the day of the event where the healthcare providers actually goes in, or Rose organization actually goes in, another NGO, so this woman will come out. And so that's, yeah, I think it has been very successful. There was one program that we did last year, Sepida Amal, Borneo. We covered like about more than 1,000 women in 1 week. So I think that was a very successful program. So yeah, so these are the incentives that we give. But for the breast cancer side, unfortunately, we do not give any incentive for them. So what we did was that we actually have nurses that they are very passionate to do volunteer work. So they will just take their own leave. They will just go out to the rural areas with us, and they will just do it based on voluntary basis. So I did highlight this a few times to the Ministry of Health that we must give them incentives. Otherwise, like, you know, like we wouldn't go far in this program, because these people have to take their own time, they have to take their own leave, and it's just not sustainable in the future. But yes, we do need to give them some incentive. Back to you, Hayley.
Thanks, Melissa. And Belinda, do you utilise community health workers in Fiji?
Thanks, Hayley. Yes, we do. We have a project which we will be rolling out next week, where we work closely with the community health workers. So these are the eyes and ears and feet on the ground in the community. Some of them, where they're located out in the highlands, there is really no health center available, so they need to travel far to get to the nearest health center. With the work that we've done with the first cohort of community health workers, we conducted a training program for them to upskill them, and in terms of remuneration, we were able to give them a daily subsistence allowance. They are paid by the Ministry of Health, but recruited by the Ministry of Itoke Affairs. So these community health workers sit within the villages, sit within isolated communities. We also have some of them out here in the periphery along Suva. Their role has pretty much increased because of the increase of nurses relocating overseas. And so there's quite a bit of work done by the Ministry of Health with the community health workers. And I'm just happy to say that we do work with them as well.
Thank you. So we are rapidly running out of time. So I will be asking each of our panelists for your final thoughts on future opportunities that you see to close the care gap. We have had a couple of other questions as well, commenting on whether there's any national studies conducted on dietary habits and the impact on breast cancer, and also the role of technology in addressing the care gap. So if anyone would like to comment on those questions as part of their final thoughts, that would be great, but no obligation to do so. But I'll pass to Jason, perhaps, first of all, for your final thoughts.
Sure. Final thought is thank you very much for the opportunity to speak, and it's been a really interesting conversation. I would say my thought for how we can address the care gap is by keeping talking. So these sorts of things are great because we learn from other people from other jurisdictions. We find out some things, oh, that's a bit weird, that's different. I couldn't come across that before. And then you hear all of these underlying things that are basically the same. So geographic problems, access to resources, these are continual problems that exist across jurisdictions, inequity within regions, those sorts of things. So I think we just need to keep talking and learning from each other, and continuing to put pressure on our government, using each other as reasons for why we need to do certain things. We got the Cancer Control Agency launched here in New Zealand. A big part of that was comparing ourselves to Australia. So New Zealanders hate doing worse than Australians. And so we said, hey, look, Australia's doing better than us in cancer survival. We need an agency. The government went, yes, okay, let's do it. So talking to each other and collaborating within the Asia Pacific region, I think is really important and can be a real a source of change. Kia ora.
Thank you. I'll pass to you next, Melissa.
Thank you, Hayley. I do agree this has been a very fantastic session, and I do agree with Jason again. We have to keep talking, and I do agree on the coalition of voice of sort. Just to share with you all, I think recently, I think about 3 weeks ago, I think the Malaysian government has decided on health autonomy for the state of Sarawak. So I think most likely, hopefully, we are going somewhere with that. So we are thinking that if we get a health autonomy, things will be more efficient in terms of getting healthcare, in terms of getting what do you call it? Recognition, not really recognition, like in terms of social healthcare system and all that, because now everything had to go through federal centralized system. So it has been a lot of delays in referrals and all that. So we are hoping that this will actually expedite things if we do get the health autonomy. So I think that as a take-home message, I think that every gesture, every effort, no matter how small it is, if we sincerely work towards our goal, which is the pot of gold, as what Belinda Chan has said, I think we might be even able to remove this disease eventually from our lives. Back to you, Haley.
Thank you, Melissa. I might pass to you now, Amanda.
Thank you.
Thanks,
and
Hayley.
Belinda. Sorry.
Thanks, Hayley. Sorry, Amanda. We've got the DA at the end. It's been a very interesting session. Like what Jason said, you know, the underlying factors in our issues are very similar. I think back in 2019, we pushed for a South Pacific coalition. We've always been known as the Blue Ocean out here in the islands. We'd like to see our big brothers and our big sisters join us in that. Maybe it's something, I know Amelia Height is online, that we could look at pushing forward with Cancer Council Australia. If we could get this out, we could reduce cancer inequities here in the islands. We may be small, but I think when you combine the Pacific Islands or the South Pacific region, we're probably the same as Australia. Sorry, bigger than New Zealand, but the same as Australia. And so we need to continue with these conversations. We need big help. We need a huge hand from our big brothers and sisters out there to help us navigate our way through this and to improve cancer outcomes for our people in our own countries. But we won't be able to do it without your help. And more importantly, we won't be able to do it without government will. And so it's something that we will need help with in getting or in convincing government that it is a priority. Thank you.
Vinaka, Belinda, thank you. And over to you, Amanda, for our final words.
Thank you so much. And I would echo everyone's previous comments about the opportunities for us to continue these conversations. And I think what we have learnt and continue to invest our time in is finding the shared goal, that ultimate goal that we've all got, whether we're working in government or whether we're working in a not-for-profit. And when we can find that shared goal, then we're able to find those points of connection where we can, as Jason earlier pointed out, find the strength, the way that we can partner, what can we contribute, and offer that to make a difference and to reduce care inequities. For us, it's really important that people are able to have the best cancer care and cancer experience. And there's so much that I've already learned from this conversation and things to follow up. And I would encourage people to continue these conversations outside of a forum like this. Thanks so much, Hayley, for organising and for the opportunity.
Well, a big thank you to all of our panellists. It's been absolutely brilliant to hear your expertise, and congratulations on all of your efforts and ongoing work. And we're all committed to working together. On World Cancer Day, we know that everybody has the ability to make a difference. And I'm really glad that through the session today, we've been able to share some of those experiences to make progress on lessening the global impact of cancer. You can have a look at the UICC's World Cancer Day website for more activities. World Cancer Day is coming up on Sunday, the 4th of February, and there are some great things planned. You can also read the equity report that UICC has just released, which has a great snapshot of some of the challenges and opportunities around the world. in terms of the McCabe Centre, you can follow us on LinkedIn, X, you can sign up to our newsletter, and feel free to email us through any questions. Thank you so much for your attention today. It's really been an inspiring discussion, and we're wishing you all the best for future collaboration on closing the care gap.